Thanks. Dear Chairman, ladies and gentlemen, thanks for getting the opportunity to talk about this specific patient population. So the whole study was based on the increasing prevalence of obesity in children and adolescent patients during the last 2 decades. And we are currently facing a rate of about 20% of obese children and adolescents in the United States. Together with this increase in the prevalence, we also face a massive burden due to comorbidities and diseases of these patients due to our healthcare systems. And we found that the costs have tripled during these 20 years too. One of the main problems of this study population is that most of these children carry on their obesity to adulthood, especially if one of the parents is considered obese too. So we are all familiar with comorbidities, or with these listed comorbidities in adult patients, but more and more we see these diseases and this type of diseases already at very low ages. And these comorbidities usually result in a very poor life quality of these patients, which is comparable to cancer patients. Additionally to these comorbidities, these children and adults also face psychological problems like poor body image, sexual dysfunction, and also poor education. So therefore we have to treat these patients, but unfortunately we only have conservative methods which can reduce the weight of about 10%. And it's also a big issue that this weight loss is not of long maintenance. So therefore, bariatric surgery is already considered in children and adults. That is the only practicable method to achieve long-lasting weight reduction. So the indications for surgery in children and adolescents is mainly adopted from the NIH and IFSO criteria, with a BMI as one of the main screening tools, with some kind of cutoff around 40 kilograms per square meter. It's important to mention that all children who will receive surgical treatment should have already reached their skeletal maturity, which is usually considered to be reached in girls at the age of 13 years and in boys around 15. And this age is also considered as the age where these patients achieve their decisional capacity. In our center, we also face a big impact on comorbidities, which are associated with the obesity of these children. And it's also important to mention that the children should have tried conservative weight loss methods in organized centers and have failed for more than 6 months to maintain their weight loss. So therefore, these likely candidates should be treated in specialized centers and in a multidisciplinary approach. So we report here now on all our patients who have already passed the 5-year follow-up time point. 50 patients have been treated between 1997 to 2004. The mean age of this study population was around 17 years. Even 5 patients were younger than 15. The mean BMI at the time of surgery was 45.2 kilograms per square meter. And 2/3 of our patients suffered from at least one comorbidity. The operation duration was not longer than 1 hour, and we performed 3 additional cholecystectomies. So these slides provides you with the follow-up data of the BMI, and we see that the main weight reduction was achieved during the first 2 years after surgery, and the achieved weight loss was quite stable then for the next few years during follow-up. Here you're provided with the data, and we see that after 3 years we have a nearly 35% reduction of the BMI. We had already 2 patients after 3 years we had to switch to gastric bypass, and after 5 years you see that the BMI remained quite stable, but we have already switched 7 patients, and 3 patients were already lost to follow-up. We evaluated the quality of life with established lifestyle questionnaires like Barras and Moorhead, and we see that we could achieve quite acceptable results. Before I mentioned the impact of comorbidities, and we see that after 3 years, about 1/3 of the comorbidities have improved and 2/3 have already been resolved. And after 5 years, we see already that most of the comorbidities are resolved. Unfortunately, we have to report about complications and treatment failures. So we faced 2 band dislocations, 2 leakages, and 2 port rotations. And we see that comorbidities, especially in treatment failure patients, remained or even new ones occurred. We considered treatment failure in patients where the extensive weight loss was less than 25%. So we have 8 patients who had to be classified like that. We have already switched 6 patients to bypasses. 1 patient rejected the treatment option, and 1 patient still tries to lose weight with his banding. So in conclusion, we can say this procedure with banding is safe and practicable also in children and adolescents. It's important to mention the appropriate timing of surgery. We shouldn't wait too long with it. To our mind, it's very important to make a very careful patient selection, and all these patients should only be treated in experienced centers in a multidisciplinary approach. As I mentioned before, additionally to the BMI, the comorbidities and the severity of these comorbidities should have impact on the indication for surgery. And we could show that we could improve, additionally to weight loss, we could improve the quality of life of these patients. Thanks for your attention.